Polotsky is professor in the departments of anesthesiology and critical care medicine, pharmacology and physiology, as well as medicine, here at the GW School of Medicine and Health Sciences. He's vice chair for research in the Department of Anesthesiology and Critical Care Medicine, where he's implementing a vision for neuroscience, pharmacology, and physiology and pain research. Before coming to GW, Dr. Polotsky was a professor of medicine at the Johns Hopkins University School of Medicine, which is where we first met back in 2006 when I joined the team of a study for which he was a co-PI. And I can tell you that Dr. Polotsky, or Seva as I would call him, is a brilliant scientist and a very kind person. I'm thrilled he's now here with us at GW. Dr. Polotsky is an internationally known clinician scientist with expertise in neuroscience and a focus on sleep medicine. He is a world-renowned expert in animal models of obstructive sleep apnea and metabolic complications of sleep apnea. His research interests include hypoxia, obesity, and metabolic syndrome, while currently researching chemogenetic manipulation of the innervation of upper airway musculature with a goal toward developing gene therapy of obstructive sleep apnea. Dr. Polotsky's career has been dedicated to studies of the pathogenesis of sleep-disordered breathing and its complications, and he has been continuously funded by the NIH since 2002, which is a huge accomplishment. Recently, he became involved in research into opioid-induced respiratory depression, or ORID, and is the recipient of an R61 R33 grant funded by the NIH HEAL program to develop a novel treatment for ORID. Dr. Polotsky is very well published. He's served on multiple NIH study sections and on the editorial board for several journals, including Frontiers in Sleep, the American Journal of Respiratory and Clinical Care Medicine, and the European Respiratory Journal. For perspective, his work has been cited just shy of 16,000 times. Also, he earned his MD and PhD from St. Petersburg State Pavlovsk Medical University in St. Petersburg, Russia, and he's a former chair of the American Thoracic Society Sleep and Respiratory Neurobiology Assembly. So with that, I turn it over to you, Seva. Thank you.
Thank you very much for introduction. And it's my pleasure to present, and thank you for inviting me again. So, and with this, let me start my presentation. And you can see my screen, right? Perfect. Okay. I have no conflicts. And my task today is to talk to you about sleep disorder breathing, about the mechanism of sleep disorder breathing, consequences or amelioration or treatment. First, we'll talk about mechanism. Most common form of sleep disorder breathing is obstructive sleep apnea. What is obstructive sleep apnea? Obstructive sleep apnea is a recurrent closure of the upper airway when we sleep. This condition leads to intermittent hypoxia, intermittent drops of oxygen level in blood, pressure swings, transthoracic pressure swings, fragmentation of sleep, and hypercapnia or buildup of CO2. This is a typical screen shot of the sleep study, which Dr. Jane and I look at this almost every day. And as you can see here, it's the I leads here and the EEG leads, EMG, EKG, and this is oxygen tracing and airflow. This is airflow and effort. As you can see that this patient has intermittent severe drops in oxygen level in the blood. Why is it happening? Because the flow stops while effort continues. So basically patient cannot breathe because the airway is closed. The effort continues, but the air doesn't come in. It's an incredibly common condition. Obstructive sleep apnea, diagnosed by apnea-hypopnea index, number of time breathing stops per hour, greater than 5, greater than or equal than 5. It's present in 54 million patients only in the United States, close to 1 billion patients in the world. Moderate to severe apnea with significant health consequences is observed in 24 million patients in the United States. In obese individuals, it's even much more common, and with prevalence in the neighborhood between 50 and 80%. So what are the traits contributing to sleep apnea? First of all, it's compromised upper airway anatomy. So without this compromise, it will not happen. Then poor protective neuromuscular reflexes. It's very easy to understand. Nobody has apnea awake. Why? Because the neuromuscular reflexes protective. When they don't protect, they develop apnea. And two, I would say secondary, but also important disturbances, they should be present. Or can be present, dysfunction of the control of breathing, which leads to overly sensitive compensation to breathing cessation. Or just opposite, sluggish compensation. Both extremes are bad. And low arousal threshold. That will become more clear from subsequent slides. Obesity leads to upper airway adiposity, which predisposes to obstructive sleep apnea. This is upright, awake MRI of the upper airway. This is the tongue. And in a lean, normal weight individual, and you see the tongue in obese individual, there is a fat accumulation in the tongue and fat accumulation around the pharynx, which results in narrowing of the upper airway. But the breathing does not stop when the patient awake. When patient is asleep, and this is fundamental paper, one of the most commonly cited in sleep medicine, a paper published in 1978, it shows that when they have mechanical load imposed by obesity, airway is starting to close. But if you have robust reflexes, you're able to protect. See, protection. If it doesn't happen, airway collapse. Now, as I said, that another important phenotypic feature is control of breathing or loop gain. So let's say airway collapse, but our response or patient response is appropriate. Then the breathing sooner or later stabilizes. What if there is an overshot? If breathing overshoots, what's happening? The CO2 is being blown away, which leads to more collapsibility of the airway and decreased central control of breathing, decreased desire by the desire to breathe. And the breathing becomes unstable. That's called the high loop gain, because when a response to disturbance is higher than disturbance itself. Finally, arousal threshold. So there are two extremes here shown. One extreme, the oxygen level dropping down very low, it's even lower than, and nevertheless, the patient does not wake up until oxygen level drops to dangerously low numbers. This is lowered arousal threshold, but when it, which is detrimental, but arousal threshold is very high, meaning the minimal disturbance here happens. Airway just a little bit compromised. Nevertheless, you wake up. That becomes also really leads to instability of the airway and frequent obstructive apnea. In the first phenotype, usually obstructive events prolong and may not as frequent, nevertheless very detrimental because oxygen level. And second condition is also detrimental because of the inability to sleep. What are the consequences of sleep disorder breathing? Well, that's the most important outcome, isn't it? Mortality. Indeed, sleep disorder breathing leads to high mortality. This is essentially survival probability, Kaplan-Meier curves, in patients who are stratified according to the severity of sleep apnea. Here it's a black broken line here, represents normal individuals without significant apnea. This mortality over 10 years period of time. This is sleep heart health data I should mention to you. It's a very large community study. As you can see, as apnea hypopnea index increases severity, so does mortality. Turns out that what's really predictive of mortality is oxygen level. So the hypoxic burden, that's a recently introduced criteria of sleep apnea severity, although it's kind of obvious, intuitive criteria, because you can stop breathing for short period of time, or you can stop breathing frequently without drop of oxygen level. You will have high apnea hypopnea index, but not much hypoxemia or low oxygen. So here it shows that if you calculate this area under the curve, how low oxygen go for how long. This is called hypoxic burden. And that's really what correlates very tightly with mortality, the degree of desaturation. Not only how many times you stop breathing, but how far you desaturate. Sleep disorder breathing, as I will explain in details a little later during the talk, leads to chronic increase in mortality due to predisposed to chronic morbid conditions. But also there is significant change or increase in acute mortality. This is actually another landmark study published in New England Journal of Medicine. This is a study from Mayo Clinic, where they look at the prevalence of sudden death. Normally, almost commonly, sudden death occurs between in patients who do not have sleep apnea or during early morning hours. It's most common between 6 a.m. and noon, as it's shown here. Well, this distribution changes dramatically in sleep apnea, and most of these patients actually die at night. We can only guess that this may be associated with severe hypoxic episodes or arrhythmia. Sleep apnea imposes a huge burden on public health. The total societal level cost of sleep apnea is more than 100 billion a year in the US alone, including 87 billion of loss of workplace productivity, 30 billion due to increased healthcare use, and 26 billion due to motor vehicle accidents, 6.5 billion due to workplace accidents. It's a huge, multiple disasters, very well publicized, very well known, been related to sleep deprivation or to sleep apnea. So what are the outcomes? Well, the outcomes are multiple. Even more recently, we actually found not only metabolic outcomes or neurocognitive, but also increased prevalence on certain types of cancer. Turns out that cancer surprisingly associated with sleep apnea severity and hypoxia severity. It's actually melanoma and renal cell carcinoma. But more commonly known and stronger evidence on association or causation, the matter of fact, between sleep apnea and cardiovascular metabolic outcomes. Increased risk of arrhythmia, especially atrial fibrillation, systemic hypertension, type 2 diabetes, fatty liver disease, hyperlipidemia, atherosclerosis, coronary artery disease, stroke, as well as pulmonary hypertension. So it's finally, at last but not least, definitely, it's neuropsychological and cognitive outcomes. Poor nocturnal sleep, daytime sleepiness, cognitive impairment, apparently increased risk of development dementia with aging, motor vehicle accident, and impaired quality of life. So this graph, this is data from very large study in Sweden. They show the prevalence of motor vehicle accident in patients with sleep apnea compared to patients or subjects without apnea. This is number of accidents per 10 years of observation. They have a lot of accidents, even a patient without apnea in Sweden. I was kind of a little impressed, 12 accidents per 10 years. But if a subject has a sleep apnea, it goes up almost threefold. And the same for all the age cohorts and for all the individual as well. There is a very strong association between sleep apnea and risk of motor vehicle accidents. Sleep apnea predisposed to the development of hypertension, which is very well proven. In this study, study from Wisconsin cohort, this is prospective study. So basically, they observe patients, they enroll patients and look at the patients who do not have hypertension and stratify them by levels of sleep apnea by quartile. And you see the quartile is a community distribution. So it's not the same as severity in patients. It's throughout the community. So as you can see that this patient essentially without apnea, with minimal apneic burdens, less than 5 events per hour. According to our definition, there's no really sleep apnea here. Mild disease and moderate to severe disease, greater than 15 events per hour. You can see even the minimal increase in number of apnea, which is not even qualified for sleep apnea, results in increase as developing hypertension, and twofold increase in patients with mild and nearly threefold in moderate to severe apnea. The same significant risk of atrial fibrillation. You see patients with sleep apnea, the much more commonly were diagnosed with atrial fibrillation than patients without apnea. Moreover, the patients in whom atrial fibrillation occurred after ablation almost invariably had a sleep disorder breathing. Sleep apnea is very tightly associated with stroke, and I will show you again a little later evidence for possible causation. And this is large cohort, more than 5,000 individuals in sleep heart health study, and look at the prevalence of stroke in men and in women. And in men, there is a very clear relationship between severity of apnea and adjusted survivorship function. That was a risk of stroke or death of any cause, and there's a significant increase in patients with apnea. Actually, in women, that was not observed. And we know that actually in sleep disorder breathing, it's very well recognized phenomena. The sex, especially in premenopausal females, it's protective. Over the last more than 2 decades, we recognize a strong relationship, at least a strong association between obstructive sleep apnea and insulin resistant and obstructive sleep apnea and type 2 diabetes. This is first 2 papers which describe it in large cohorts, but it's a cross-sectional study. Basically, it's kind of like a snapshot relationship. But the prevalence of sleep apnea in type 2 diabetes is very, very high. As you can see, there's different cohorts described in different studies. If you can see the Foster study, the relationship was the strongest. Nearly more than 8 out of 10 patients with diabetes had obstructive sleep apnea. The reason why relationship here is the strongest, because this study is actually, it's a look ahead study. Look at patients with obesity and diabetes. So obesity plus diabetes invariably associated with the, almost invariably associated in sleep apnea, and I can say invariably associated with sleep apnea in men. So what are the treatments, and what is the relationship between the treatment and the outcome? Well, there are different ways to categorize treatments. And my favorite way is kind of describe treatment according to the endotype or phenotype of sleep disorder breathing. It targets compromised upper airway anatomy. The most common cause of compromise of upper airway anatomy is obesity. So therefore, the weight loss is the first kind of intervention. And let's see whether weight loss is helpful to treat obstructive sleep apnea. This is a very large study. It was done in Australia, and they compared bariatric intervention, bariatric surgery, and this is the lifestyle modification, essentially diet and exercise, more diet than exercise. As expected, bariatric surgery led to much more dramatic weight loss, 20% weight loss. Less weight loss was observed in lifestyle modifications. And sleep apnea, it was helpful for sleep apnea in both cohorts. There was significant improvement. But look, it did improve from very severe to severe. So sleep apnea did not go away in the severe patient, despite dramatic weight loss. It's interesting that the lifestyle modification was very comparable, very similar improvement in sleep apnea, despite much less effect on weight loss. That's not entirely clear why, that probably other metabolic changes occur simultaneously when you modify lifestyle. But this is most remarkable take-home message for you. So what happens when you have mild sleep apnea? And mild sleep apnea, weight loss could be curative. So this is a large cohort from Finland, and shows that if a patient lost more than 15 kilos of weight, significant weight loss, that led to dramatic improvement in sleep apnea. This is mild apnea from 5 to 15 events per hour. So it's a significant improvement. And indeed, weight loss more than 15 kilos, most of the patients' apnea was cured. Well, there's no data so far. I know I kind of can predict this question about new drugs, GLP-1 agonists. There is no data. There is a large clinical trial going on whether there is a benefit for sleep apnea beyond weight loss. Well, most common therapy for sleep apnea is CPAP. That's actually a revolutionary intervention. That was I think one of most significant really intervention in medicine last century. In 1981, a physician scientist from Australia, Colin Sullivan, invented CPAP and published this in Lancet. So what does it do? And it blows air and classical CPAP in the nasal passages and nasal mask, and splits open airways. This paper was cited nearly 4,000 times. And well, there was some, I would say, incremental improvement of CPAP. There's no dramatic development over the last 4 decades, but there was incremental improvement. 2 main types of CPAP treatment now. It's CPAP at the fixed pressure, continuous, constant set level of pressure. And this type of treatment requires special sleep study with a CPAP titration to establish therapeutic level of pressure, and automatic CPAP, auto-titrated CPAP. And in this case, after sleep apnea is diagnosed, patient just put on APAP without titration, and the machine adjusts pressure by itself, depending on the flow. So both these types of treatment in uncomplicated sleep apnea, they're pretty much equivalent. So what effects does CPAP have on consequences, on manifestation of sleep apnea? This effect of treatment with CPAP intervention on motor vehicle accidents. Well, I have to say a couple of words here about compliance with CPAP. There is an arbitrary criteria that patient has to use CPAP greater than 4 hours a night on 70% of the nights. It's entirely arbitrary criteria that was invented by a group of experts in the 90s when they just wanted to look at the effect of CPAP. And that was after, it was basically adopted by Medicare based on this paper of the 90s. So as you can see, nevertheless, the patient who are compliant with CPAP has significant improvement in motor vehicle accidents. And the patients who were not compliant with CPAP, it actually was opposite. Okay, and this is the, in this paper, well, this is meta-analysis of multiple clinical trials or randomized clinical trials on the effect of CPAP on hypertension. So as you can see, nearly all the studies showed significant effect of CPAP treatment on hypertension. This is all comers on the left, all patients with hypertension and sleep apnea. And you can see the effect is modest, but it's 24 hours. 24 hours improvement in blood pressure, 2 millimeters of mercury, is actually associated with improved cardiovascular outcomes. But look what happened in resistant hypertension. What is resistant hypertension? That's when patient remains hypertensive despite being adherent to treatment with 3 or more antihypertensive medications. So if 3 or more antihypertensive medications do not work and patient is taking them, it's likely that sleep apnea is present. And in this case, CPAP may actually make a huge difference, 5 to 7 millimeters of mercury. Well, how about mortality? This is one of the also very widely, I think this is the most cited paper, at least it has been in sleep medicine. This is observational study, entirely observational, in Spain, which was published 20 years ago, nearly 20 years ago. So what they look at, again, Kaplan-Meier curves here, cumulative incidence of fatal cardiovascular events versus and non-fatal cardiovascular events. And red line shows severe sleep apnea, and the other line shows different types of apnea, and the blue broken line shows sleep apnea treated with CPAP. As you can see that there was an association between sleep apnea. I emphasize association. It's an observational study, cannot study causation. There was significant association between severe apnea and fatal cardiovascular events and non-fatal cardiovascular events. And CPAP seemed to reverse it. Well, based on this data, there are several large studies were set up. It took many years to set it up. This is SAFE, international, multi-center, randomized, parallel group, open label trial. It's called SAFE. It enrolled 15,325 patients with coronary artery disease or cerebrovascular disease, and nearly 3,000 were diagnosed with moderate to severe sleep apnea and were randomized to CPAP versus usual care. They were followed up for nearly 4 years. So, and CPAP group was 1,346. And this is multinational studies. It's actually predominantly, it was sponsored by ResMed. It was predominantly in Asia, Europe, and South America. There are some centers in the US. Well, that was very disappointing. Basically, SAFE showed no effect of CPAP on cardiovascular mortality and morbidity. Composite endpoint, death from cardiovascular cause, MI, stroke, hospital admission for heart failure, unstable angina, and TIA. We look at different ways and they still didn't see any effect. So basically, SAFE study showed no effect of CPAP on cardiovascular mortality and morbidity. Why is that? Well, CPAP adherence was only 3.3 hours per night on average. The disease was predominantly moderate. The AHI, apnea-hypopnea index, was less than 30. Patients were overweight but not obese, which is much more typical in the US. Based on BMI and oxygen desaturation index, the hypoxic burden was mild. And it was insufficient follow-up, probably 3.7 years. This degree of apnea, if it has detrimental effects, probably we can only guess it may take longer. But sub-analysis showed a CPAP adherent patient had a lower risk of stroke, which is an important finding. This is a different study. That was a European study, RICATSA. That's effect of CPAP on coronary artery disease in patients who are undergone either stent or bypass surgery. Again, there was no effect. And again, disease was predominantly moderate. Patients were predominantly overweight. And again, hypoxic burden was mild. Again, was low adherence. And again, adherent patient appears to benefit. And this is a large meta-analysis. It was published 3-4 years ago. an American Journal of Respiratory and Critical Care Medicine, essentially combine multiple, these two studies, some other studies were combined, and look at the combined outcomes. The primary outcome was cerebrovascular or cardiac death plus stroke plus MI. And apparently CPAP did improve that. About 32% improvement, that was statistically significant. Secondary outcome was borderline or significant. First ever cerebrovascular and cardiovascular event. But appeared to be there is a significant relationship with the decrease, almost twofold decreased risk of stroke. But there was no effect on cardiac outcomes or overall all-cause mortality here. So we can summarize that sleep apnea is highly prevalent in cardiovascular disease. Severe sleep apnea leads to cardiovascular morbidity and mortality, at least it's associated with cardiovascular morbidity and mortality. Hypoxemia, hypoxic burden, is a key contributor to cardiovascular disease and sleep apnea. Sleep apnea causes hypertension. This is proven. CPAP decreases blood pressure in hypertensive patients. And sleep apnea may contribute to the development of atrial fibrillation, stroke, and coronary artery disease. Randomized clinical trials in cardiovascular disease did not show benefit of CPAP for primary endpoint, but indicate benefits in cerebrovascular disease. And the studies were done only in moderate sleep apnea with mild decrease in oxygen. And CPAP adherence was poor, and the studies may have been not sufficiently long. How about diabetes? Does CPAP affect diabetes? Previously, at the beginning of my talk, I showed a very strong association. About 13 randomized clinical trials were done in different populations of apneics, different outcomes, aside insulin sensitivity, glycosylated hemoglobin, fasting blood glucose and insulin. 6 studies showed some improvement and 7 showed, unfortunately, none. And again, it's a big pitfall of all the studies. Adherence with CPAP was low. This study, I showed a separate slide for that for a reason. In this study, patients were actually admitted as inpatients to the clinical research unit for 2 weeks. And they were essentially forced to sleep 8 hours with CPAP, or ask rather, I should say, for 8 hours with CPAP. And this patient was pre-diabetes. So they didn't develop full-blown diabetes, but they had elevated fasting blood glucose between 100 and 125 milligram per deciliter, or elevated glucose after glucose challenge in oral glucose tolerance test. And there are 2 parameters here show the benefit. This is area under the curve of intravenous glucose tolerance test, show how body can handle glucose, was significant improvement in CPAP group, and this is placebo compared to placebo. And there was significant improvement in insulin sensitivity. But in this study, again, patients had to wear CPAP for at least 8 hours. This is probably the largest, one of the largest studies. And none of the diabetes studies were really big. That was 298 patients with type 2 diabetes, increased hemoglobin A1C. Insulin was exclusion criteria, no previous CPAP treatment. And for CPAP versus usual care. And compliance was kind of just hair above the borderline for adherence for 3 months. And again, it was showed no effect of CPAP on hemoglobin A1C. So basically, we conclude that sleep apnea is associated with type 2 diabetes, but causality is not established. CPAP treatment may improve glucose control and decrease insulin resistance in compliant patients with prediabetes. Well, we talked about CPAP in details. So first of all, one thing I didn't kind of include the slide, but there is a consensus among the sleep physician expert that CPAP is still by far the best possible treatment. There is also BiPAP, bi-level ventilation, and there has no advantage and basically not advisable. Can be used sometimes for comfort, but we basically prefer CPAP in patients with sleep apnea. What if patients cannot tolerate CPAP? Adherence with CPAP is 50%. Oral appliance can be an acceptable alternative. Oral appliance is made by a dentist, and basically what it does, it's usually, there are several different types, I have to say, but this most common type. It has two pieces, one for the upper jaw maxilla and one for lower jaw mandibular, and the principle is very gradual advancement of the mandibular piece to open up retropharyngeal here space. So again, this treatment targets mostly anatomy, right? Like CPAP, splints open airway. This treatment also targets anatomy. Sleep study before and after should be done. Effective in mild to moderate apnea in non-obese patients. And patients should be under care of a sleep physician. And the appliance should be made by a dentist. It should be adjustable. Okay, so this is the very interesting slide, in my opinion, because it showed efficacy versus effectiveness. Efficacy is how helpful treatment is in ideal situation. And effectiveness, what's really happening in the real life. So look at the efficacy data. So this is CPAP and versus mandibular advancement device, oral appliance, and percent of patients who report complete resolution of sleep apnea, much higher with CPAP, right? Much higher. So partial is better with mandibular appliance and failure high with mandibular appliance. But adherence to CPAP, as I said, 50% across the board, at least in the United States. And the mandibular advancement device adherence is 70%. If you look at the real sample of patients, you can see that this is Epworth scale of sleepiness, effect on sleepiness score. Pathological sleepiness is more than 10. But any decrease is good. The lower, the better. And you can see that CPAP and mandibular appliance, they have about the same effect on sleepiness. And the same effect on blood pressure. Look at that. Effect on systolic blood pressure and mean blood pressure and diastolic blood pressure. And this is for oral for the dental appliance versus mandibular appliance versus CPAP. Actually, I realize that legend is gone somehow, but the dark square here, the dark field square, field oval here, it's CPAP and open is mandibular device. It's about the same. So it's definitely acceptable alternative in some patients. How about surgical treatment? There are several surgical treatment modalities for sleep apnea. And again, it targets anatomy, anatomical predisposition to sleep apnea. So what are the types of surgery? Well, surgery on nasal cavity. So why is it important? Because if you don't have a nasal breathing, patient doesn't have nasal breathing, patients tend to breathe at night with their mouth open. And now imagine the mouth is open up. Open up, the mandible goes down. The amount of retropharyngeal space where the airflow is decreasing. So that's why when nasal breathing is improved, it improves sleep apnea. So, if you polypectomy, ablation of turbinates, it's all kind of has a definitely has utility. If nasal breathing compromised, makes utility to fix the nose. Makes sense to fix the nose. So there are and septoplasty. The same with adenodectomy. So then oropharyngeal surgeries, tonsillectomy, UPPP, it's uvulopalatopharyngealplasty, and this is the same but with the laser. Then the skeletal surgery, and this is very dramatic surgery with the expansion, basically rebuild and reconstruction of bone structures to improve, to increase the retropharyngeal space. Including mandibular advancement, hyoid myotomy suspension, all pursues the same goal. And finally, this is at the bottom here. That's the only treatment we had before CPAP, before 1981, patients with severe apnea, in order to save their life, they had to do tracheectomy. It's very, very rare now, as you can imagine. And that's just to show you what happens in different types of surgery. This is the airway, yeah, tonsils removed, tonsillectomy. This is UPPP. See, that's a big portion of soft palate and uvula removed. Well, tonsillectomy, adenodectomy, it's a treatment of choice in children. It's a big risk factor. And children, and some data, the non-obese adolescents and non-obese adolescents, it's also very helpful. And the polypectomy, septal nasoplasty can be helpful in adults. But UPPP, there is really no data that may be effective. There is no data. Now, skeletal surgery. How about this dramatic surgery I described to you? Well, in this case, the patient should, that may be recommended in patients with significant skeletal abnormalities. Severe retronatia, it's most common, right? Or small low jaw. Patients are referred to craniofacial surgeon. They do kind of tridimensional reconstruction. This is relatively uncommon compared to huge risk imposed by obesity. Nevertheless, it may be helpful in the subset of patients. Okay, now if reflexes are dead, the patient will have no means to protect airways and will have apnea. And there is a treatment now for that. And treatment is novel treatment. Well, it's been approved by FDA already for 5 years or so. Electrical stimulation of the hypoglossal nerve. So who is it indicated to? The patient selection criteria, now they're a little bit more relaxed. Patient with moderate to severe apnea, but not too severe. I think AHI in an original study was less than 50. I think now they relax it slightly. BMI, body mass index less than 32. Now it's they accept patients with BMI less than 35. Very important on this relatively, you exclude patients with moderate obesity, greater than, and severe obesity, and exclude patients with very severe apnea. Then you refer this patient to ENT for drug-induced sleep endoscopy with propofol, and they examine the airway, laryngoscopy. We will do this laryngoscopy during propofol anesthesia, and to make sure that there is no concentric collapse of the airway, which precludes this surgery, this implantation. And device, there are 3 types of devices now developed, but one is approved by FDA. I will talk only about this device, which is approved now and widely used. So this inserted here in the chest area, one thin lead goes to intercostal region just to sense the breath. If patient inspires, it delivers the more thicker wire, and he applied around hypoglossal nerve. And if you turn the device on, it will deliver stimulus, and that will result in protrusion of the tongue, basically sticking tongue out. And it works. It decreases pharyngeal collapsibility, relieves airflow obstruction during sleep anesthesia, improves sleep apnea. However, it works only in about 2/3 of the patients. And we don't know how to predict what this relatively relatively stringent criteria. You know, a lot of patients included, but a lot of left out. And in this carefully selected patients, in 2/3 it will work. There's no way to predict. Right now, it's a main indication if you cannot stand CPAP. CPAP is treatment on choice. Patient will refuse to use CPAP, then we can refer this patient to hypoglossal nerve stimulation. So there is no FDA-approved drugs, but there are several promising candidates, and this is probably the most advanced. It's called eta-oxy. First of all, I'll tell you, in my opinion, the candidates will be very similar, will be competing, so to speak, with the hypoglossal nerve stimulators, similar population. And eta-oxy went through phase 1 and phase 2 clinical trials. What is eta-oxy? It's a combined drug. It's a norepinephrine reuptake inhibitor, atomoxetine, which is initially used for ADHD under the brand name Strattera, atomoxetine, and combination of antimuscarinic drug oxybutynin, which was approved historically for overactive bladder. Basically, these drugs were repurposed and combined. Pretty genius, I think. And I will not show you phase 1. This is much bigger. This is phase 2 trial. Just been published literally 2 months ago. Study, they call it Mariposa, and company name, it's a offshoot of Harvard. It's called Apnimed company. So, and 63 patients were in placebo arm, 63 were atomoxetine alone, 42 patient combination low dose, and 41 patient combination higher dose. And placebo had no effect, as expected. There was effect in all 3 groups, improved from 19 to 12, 19 AHI from 19 to 12, 20 to 11, 19 to 10. Well, obviously patients were moderate, kind of mild to moderate sleep apnea. It was an improvement significant, but not really super dramatic, but significant. There are side effects. It suppresses REM sleep, increase N1 sleep, Dr. Jane just told you, N1 sleep is not such a great sleep, and increase arousals. No significant change in sleepiness or quality of life. Maybe contraindicated in benign prostate hyperplasia, and just because oxybutynin. Patients with heart disease were excluded, concern about norepinephrine, increased level of norepinephrine. Patient with hypertension on 2 or more drugs excluded because of, again, concern for norepinephrine effect. Okay, so let's talk about, very briefly, about 2 other physiological traits. I said this is 2 important traits, anatomy and poor reflexes, and we have targeted therapy, which is approved. Well, a dysfunction of control of breathing for when patient is responding too much to stimulus, to the airway closure. So it turns out that carbon anhydrase inhibitors are helpful. The first historical drug, I mean, which is widely used, acetazolamide, which is very well known and used in as a diuretics, as a mild diuretic, and also used in inpatients predominantly with some outpatients. Also used to treat mountain sickness because it improves, stabilizes breathing. This is related drug, carbon anhydrase inhibitor, sulthiamine, and which basically stabilizes breathing. It doesn't do anything to reflexes, but it stabilizes the breathing. Apparently, may be helpful. Decrease in apnea from 61 to 40, about 55 to 33. This is not the level of AHI. This is decrease. So there is some benefit. And finally, low arousal threshold. If patients wake up to very mild stimulus, they may develop significant disease. Again, this is should be used very carefully. And some physicians consider using sleeping pills with CPAP together. But in this case, they measure apnea threshold in the lab and prescribe azapiclone to patients who had a low arousal threshold, who were waking up to very small change in airflow, and apparently they improved. So basically, you can see a lot of different interventions and a lot of work for doctors. So we should develop personalized therapy, which is a difficult task. See, Miss Truly, we want you to relax, get a good night's sleep, and we will evaluate any sleep issue you have, and they'll prescribe the treatment. Hopefully, it will be effective. Thank you for your attention.
That's great. I have to say that that really reminds me of my time in the sleep lab when I had to convince participants that, yes, you are going to get a good night's sleep here in this strange environment with all these wires on you. So thank you very much for that, Seva. That was wonderful. We are going to take a quick break. 5